Thank you everyone for joining us for our final session of Translate for the 2024 season. We're very excited today to have Dr. Robert Kushner, an endocrinologist and an expert in the fields of obesity and anti-obesity medications to join us today to speak a little bit about that topic. A quick intro on him. So Dr. Robert Kushner is a professor of medicine and medical education in the Division of Endocrinology at Northwestern University, as well as the director of the Northwestern University Center for Lifestyle Medicine in Chicago. He is the past president of the Obesity Society and a founder of the American Board of Obesity Medicine that certifies physicians in the care of patients with obesity. Board certified in both internal medicine and nutrition. Dr. Kushner is a passionate clinician, educator, and researcher and advocate in helping to improve the lives of those affected by overweight and obesity. He has authored over 250 original articles, reviews, books, and book chapters covering medical nutrition, nutrition education, and obesity, and is an internationally recognized expert on the care of these patients who are overweight or obese. We're very excited again today to have him to share his perspective. Feel free as the talk is going forward to put questions in the chat, and myself and Ani, my colleague, will moderate those questions towards the end of the session. And with that, we'll pass it to Dr. Kushner to start his talk. Oh, I think you're muted. Yeah, happens.
I am indeed muted.
Yeah.
Thank you. Let me share my slides to get started. Thanks for the invitation, by the way, to present. And let me just get myself, make sure I'm all set here. And you should be set, right? You guys can see it?
Yep, we're seeing that clearly. Perfect.
Thank you. Well, thanks for the invitation to talk about obesity. And I was asked to speak about anti-obesity medications, which we often call AOMs, past, present, and future. So I'm going to give you kind of a high-level overview of the direction we've taken, as well as show some data of where we're at and a peek into the future. These are my conflicts of interest, mostly advisory board or advisor to the companies. And so I've been in the field for quite some time now, and I truly feel this is one of the most exciting times in my professional career, and I really think we are at an inflection point regarding the delivery of care for patients living with obesity. And I consider an inflection point based on kind of three major bullet points. One is we have increased effectiveness of medications, highly effective medications we have not seen before. And that is due in part to a changing paradigm of the treatment target, which I'll go over with you, and the pleiotropic nature of those medications have moved us beyond looking at weight loss as a goal and more towards the health of the individual. I think that's consistent with medicine in general, regardless of what the chronic disease is we're treating. We want to treat the chronic disease, but we always have an eye towards improved health. The paradigm shift that I'm referring to when I talk about inflection point is a large part of the understanding and turning our direction called what's called the gut-brain axis, in which various pancreatic hormones listed here, GIP, GLP1, glucagon, amylin, and PYY, among others, have been identified regarding how they work. And by synthesizing them through the pharmaceutical industry, we're able to impact appetite that occurs in the brain. So that's why it's called the gut-brain axis. Prior to now, which I'll go over in a moment, that has eluded us, and we've focused on more of a simplistic role or opportunity to treat obesity. So before I get to the gut-brain axis and what the current highly effective medications look like, I want to take a look back a little bit, or the past of where we came from. And what you see here is a timeline going back 90 years or so. with medications that have been developed, removed from the market, and added to the market, and you see on the bottom is the legend. Everything in gray has been withdrawn for one reason or another. Everything in red are anti-obesity medications currently on the market, and the ones in red with that green border are what we call nutrient-stimulated hormone-based therapeutics. If you go towards the left, phentermine was the first medication really identified in 1959, and I'll show you in a moment. It's an amphetamine derivative. It remains the most highly prescribed medication in the market in the United States. I think it's probably due to it's the cheapest. It's the only one that's available that's generic and therefore costs $15 a month or $20 a month, depending on where you get it. I think physicians have familiarity with it, and although not the most effective, is the most highly prescribed. Orlistat was approved in 1999. I'll show you in a moment. It's the only medication on the market that does not affect appetite. It works by reducing the absorption of some dietary fat, about 30% from being absorbed in the body, and you pass it in your waste. And then there's a whole slew of medications towards the right that have been approved over the past decade that really make up the majority of the medications we have now for obesity. But I also want to draw your attention to how many gray boxes there are here and the years that they've been withdrawn. And they were withdrawn appropriately, mostly because of either cardiovascular side effects that were not acceptable, potentially risk of cancer, and in one case, rimonabant due to increased risk of suicidal ideation and behavior, something we really can't tolerate, right, among medications. But I think the long-term legacy of all these drugs that have been removed is that clinicians, I think, are hesitant to prescribe medications because of this legacy effect of it's going to be withdrawn, I'm potentially harming my patient. And I think it gives them pause to jump in and proactively treat patients for obesity. That, of course, along with the fact that obesity is not taught very much in medical schools regarding etiology, pathophysiology, approach to the patient, lifestyle support, and so forth. So if you add the lack of education with this graveyard of medications that have been withdrawn, I think it does lead to an inertia when it comes to treating obesity. I hope that will change soon, particularly with the availability of these highly effective medications that I'm going to go over with you. And patients now across the country, for the first time in my career, are making an appointment with their primary care professional, wanting to have a conversation about obesity and asking, are they a candidate for these medications that they're hearing about either from other patients or probably mostly from social media and influencers that are taking it. So it's kind of a push-pull, and hopefully all of it will lead to increased care for patients living with obesity. Early approaches to anti-obesity medications were really based on our simplistic understanding of appetite regulation. And it was identified way back in the 1950s from animal studies, primarily, that the appetite center was housed in the hypothalamus, particularly the arcuate nucleus. It's called the appetite control center. And around the same time, it was noticed that people who were abusing amphetamines or taking amphetamines for a variety of reasons back then had lost their appetite and were losing weight. So it's kind of a serendipitous finding that amphetamines could reduce appetite. And phentermine, which you see up at the upper right there, is an amphetamine derivative where you add a methyl group on this aliphatic side chain based on this backbone of amphetamine, and that's really where phentermine got started. But also shortly with different, again, animal studies, different monoamine transmitters like serotonin and dopamine were also identified to be involved in appetite. And on the bottom is fenfluramine, which is a serotonergic agent. And it turned out that the combination of phentermine and fenfluramine, dubbed fen-phen, was used very popularly in the 1990s, highly effective in helping people lose weight because of profound reduction in appetite. Unfortunately, it led to left-sided heart disease, kind of like a carcinoid valve on the left side of the heart, and led to the removal of fenfluramine and dexfenfluramine from the market. Phentermine, however, has remained. Well, over time, our understanding of the hypothalamus and different triggers that went into the hypothalamus that caused appetite regulation matured, particularly in the 1980s, 1990s, where we understood more and more about signals from the periphery were providing information to the hypothalamus, and we understood more what was going in the hypothalamus rather than a dual system of increased appetite or decreased appetite. Now we're looking at the neurotransmitters and the different signaling pathways that you see here, and that started to give way to our understanding of appetite regulation, and eventually why individuals living with obesity had a dysregulation of appetite that we now can treat. We've also learned over time that the centers in the brain involved in appetite were not just singularly focused in the hypothalamus, but really involved many other areas of the brain that we now call the hedonic reward centers of the brain, like prefrontal cortex, the amygdala, ventral tegmental area, and so forth. And all of these areas really have to do with appetite. And as I'll show you later, the medications we use today actually hit multiple areas in the brain, not just the hypothalamus, and this becomes important regarding really the true understanding of how animals and humans regulate appetite, and can then now, instead of falling into a medication that we happen to see causes weight reduction and then using it, we're now using more of a targeted approach to develop pharmacotherapy when it comes to appetite reduction. So let me now get into these incretin-based hormones that gave way to our current pharmacotherapy. And I wanted to start, rarely do I give a personal observation from my own professional career in this field, but I want to give one because it dawned on me when I was presenting this that what I didn't understand when I initially worked as a physician nutritionist at the University of Chicago in the early 1980s, we actually were seeing what turned out to be the incretin effect, but we didn't know it at the time because GLP1 was not identified till the late 80s. But to go back to my story, in the early 80s, as a physician nutritionist, I used to run a nutrition support program in the hospital in which we would give individuals intravenous feeding called hyperalimentation at the time. Now we call it total parenteral nutrition, or TPN. And we would either feed people through TPN, which is intravenous feeding, or enterally, right through the mouth or directly into the stomach. And we were observing something very, very important and profound, is that when we would give dextrose in the IV solution, we would almost always have to give insulin in the IV bag in order to control the blood sugar of the patient. Whereas if we gave the same amount of sugar in an enteral formula, we didn't have to give insulin. And you see that towards the right here, that you get this profound insulin response when you give the same amount of sugar orally versus intravenously. And that was dubbed the incretin effect. We didn't know it at the time, interestingly, but it was clinically, we saw it all the time. And the incretin effect is the difference between your insulin response from an oral delivery versus intravenous delivery, and that's called the incretin effect. You could actually measure that, and it was soon identified, really in the late 80s or earlier, that the incretin effect was really governed by two gut hormones, GIP, which is now called glucose-dependent insulinotropic polypeptide, or GIP, and the other is GLP1, which is glucagon-like peptide 1. And you can see their effect on the giving oral or isoglycemic infusions. Most of the incretin effect actually is from GIP, that gut hormone, not from GLP1. So you kind of think about, well, why aren't we talking about the GIP drugs rather than the GLP-1 drugs today? And it's interesting, it's because it was initially looked at in individuals with diabetes, and individuals with diabetes have a blunted GIP response. In other words, when you have high blood sugar, GIP does not cause an insulin-related glucose-dependent response, where GLP remains active. So the pharmaceutical industry really turned to GLP-1 to potentially help people with diabetes, and turned a blind eye to GIP, even though it really is responsible for more of the incretin effect, because it wasn't effective in people with diabetes. Well, fast forward, which I'll get to, it's very active in people without diabetes. So GIP is now being looked at again now that we understand its biology much more. So these gut hormones, which are so important now in obesity care, got its origin in diabetes because of the effect of insulin response. So they were further explored, and GIP became really an important factor in understanding the response to blood sugar. And you see in this diagram here, when you eat, the intestine releases GLP-1. It will slow gastric emptying. It may reduce appetite, goes to the pancreas, and then increases insulin, suppresses glucagon. We've known that for a while. So the pharmaceutical industry said GLP-1 is an interesting target, and there's two ways that we can help people with diabetes get a better insulin response if we could increase GLP-1. One, towards the bottom here, is to develop DPP-4 inhibitors, stands for peptidase 4 inhibitor, because native GLP-1 is degraded very quickly within minutes. So if you can give an inhibitor to the enzyme that breaks it down, we can have naturally occurring GLP-1 increase and remain in the circulation longer. And that's the origin of DPP-4 inhibitors. And they're modestly effective because you're not getting the GLP-1 to increase that much. More effective, however, is to give GLP-1 receptor agonists. So if we got the structure of naturally occurring GLP-1 and then synthesize it, we can then give it back to people by an injection because it's a peptide. And that's the way that the field has been going. However, you still had to, if you're going to synthesize GLP-1, you have to be able to increase its half-life because it's removed within minutes. And this is an example of semaglutide, which is the drug that's really taken the country by storm. The trade name is Wegovy or Ozempic. But it's just to show you structurally how many of these other GLP-1 analogs are actually made, is that by substituting certain amino acids, you can reduce the degradation to DPP-4, and by giving a fatty acid side chain that links to albumin, you could increase its half-life. So as an example here, semaglutide, which is kind of a prototype here, has 94% homology to human GLP-1 and a half-life that goes almost a week. So you clear from the body in 4 to 5 weeks because you do half-life and you eventually clear from the body, but you could dose it once a week and you have a pretty good steady state. So when that was developed, along with many other GLP-1 receptor agonists, it has really become a mainstay for people with diabetes. And what I'm showing you here are the once daily GLP-1 analogs. One of the first ones was liraglutide, and it's still around, Victoza. And you can see all these drugs were developed really in the past 14 years. They're really new. The oral form is called Rybelsus, and the once weekly are the one that people prefer. And I want to show you towards the right here, semaglutide, approved for diabetes, called Ozempic. And Ozempic is the trade name that's gone around the country, right? Got one Ozempic, but that's the one that's actually approved for diabetes. And the more recent kid on the block towards the right is tirzepatide, and the trade name is Mounjaro. And that was just approved 2 years ago. Once a week injection. They reduce hemoglobin A1C from anywhere from 0.8% to 2%, which is actually pretty active. And if you then add another drug with it, like metformin or something, you could end up with really, really quite significant reduction in people with diabetes. And I also want to point out now, because I'm not going to talk about side effects much later, is that they all have potential side effects that are gastrointestinal in origin: nausea, diarrhea, vomiting, constipation, abdominal pain. They have common side effects. And clinically, we're able to mitigate that by changing the diet, slowly escalating the dose, and so on. We're pretty good about dealing with that right now. So the origin of the drugs I'm going to turn my attention to for the remainder of the talk really began with diabetes for reasons that I'm presenting you here. So if we now look at the incretin hormone, GLP-1 and GIP, I put a box around beta cell action because that was the early identification of its utility. But what was not focused on until a little bit later is the promotion of appetite reduction. We knew it from the early on, but the marketing of it and the therapeutic potential really seemed to be in diabetes. And if patients with diabetes lost a little weight because their appetite went down, that would be fine. But it really wasn't looked at as a separate anti-obesity medication. So that kind of started to turn the tide. So let me turn to present now. I'm going to talk about the origins of the current medications, but really go through the present medications with you. Why are these highly effective medications jumping out? And some of the data behind them, so you get a feel of why we are so excited about the medication in our field. So I told you before that GLP-1 affects appetite, and these are, and you can see the studies began about 10 years after GLP-1 was identified in the lab. And what we're looking at here is infusions of just native GLP-1 into humans. And what you see is in a short, 4-hour period of time, that's pretty much how these were done. You see a reduction in appetite, which is done usually by visual analog scale, things like that. And it's a reduction of about 400 calories or so during that period of time. If you look towards the bottom, it's in kilojoules, but I gave you the correction there from kilojoules to calories. And again, the problem with this is that you can't just have someone come in and hook up an IV and give native GLP-1 to reduce appetite, right? You have to develop synthetic versions that would be resistant to the proteolysis of DPP-4 and also change the molecule so you can give it once a week. And that's where we are now, in semaglutide and tirzepatide are examples of it. But this is really the beginning of saying, you know what, we got something here that really could be helpful for individuals with obesity. And indeed, if you give GLP-1, what you see is that the response is associated with activation in many areas of the brain that regulate appetite and food intake. And postprandial increases in plasma GLP-1 concentrations are correlated with increased regional cerebral blood flow. And you see these areas, left dorsolateral prefrontal cortex and hypothalamus. So that's just to reinforce for you guys that the action of the incretin hormones, although they generated from the gut naturally, if you give them synthetically through drug, they're not working in the gut, although it does slow gastric emptying, but the role in appetite suppression is occurring in the brain. So they are centrally acting, but naturally occur from the gut. That's why it's that gut-brain axis concept. And this is kind of our modern view now of appetite regulation. We have the brain, which is the hypothalamus, we got prefrontal cortex, and we got brainstem and NTS and so forth. And it is receiving signals from the periphery, leptin from adipose tissue, very, very important. But for the purpose of our discussion, I'm going to be focusing on the gastrointestinal or pancreatic enteral hormones that I put a red box around. So understanding this, again, we don't have to be neurologists and have a specialty in neurology to understand this, but you have to have a general sense of what is going on here when we use these drugs. And this is kind of a nice schematic, I think, looking at this cross-section or a sagittal section of the brain. And we are now coining these, some of us are coining these medications nutrient-stimulated hormones. That's what we're calling them, or nutrient-stimulated hormone-based therapeutics, because these are all are stimulated by or inhibited by nutrients, and that's the term we're using. Now, before I go any further, I just want to emphasize when I say appetite, it's really important to understand what that umbrella term consists of. And this is important not only for you, but also the patients that you may see. Because when your patients take a drug like semaglutide or tirzepatide, they are going to start losing weight through a change in appetite. But it's important to interpret what is it they're feeling. And in general, what they are feeling when they use drugs like this is that hunger is being diminished. They are feeling full sooner at the end of a meal, which would be satiation. They are more content between meals, called satiety, which means they're snacking less often. They also have less enticement of foods that make it very difficult for them to say no to. We call them highly enticing foods. That would be the hedonic feature of food. And less prospective consumption of food, meaning thinking of their next meal. and motivation for it. So when I see patients, I actually go through this in kind of a layman's term to really understand what are they feeling from this medication. What I've learned from experience is some people, the predominant feeling maybe I'm less hungry and full sooner, and that's it. Others may say, in addition to that, all the foods that I had difficulty controlling and saying no to is not difficult anymore. I can pass food by my secretary's desk or at home on my counter, and it's not calling me out anymore. And I'm not thinking about what I'm going to eat for a snack tonight when I'm watching TV, and I've always done that. So it varies from person to person, but it's fascinating to listen to your patient's experience by how they respond to these medications. And I could tell you, for many of them, it is so relieving. They've been burdened for decades, if not their whole life, of wanting to eat and thinking of food and never stop eating. And it's like a drive to eat, and they never feel full. And it is so refreshing for them. And they'll often say, this must be what people who never struggle with their weight, what their life is like. And it is absolutely enjoyable and rewarding for them. So you learn so much from your patients. So let me go on. So these are the currently available medications on the market. I'm not going to go through each one with you, but I'll just say that towards the left here, phentermine, orlistat, phentermine, topiramate, naltrexone, bupropion are what we call the earlier centrally acting medications, except for orlistat that works in the gastrointestinal tract to block fat. And then the newer ones we call the nutrient-stimulated hormone-based medications really begin with liraglutide and then go down to semaglutide and tirzepatide. The third from the bottom, which is setmelanotide, is a very specific targeted medication targeted towards the MC4 receptor in the brain, and it's used for either monogenetic or syndromic obesity. So very specialized, kind of an orphan drug. It's not for general obesity. And I'll leave it to you guys to read about the medications and so forth. The other thing I want to point out there, and I just put it in bold for you, that every medication on the market except for orlistat, which is Xenical, works through appetite regulation. That is the dysfunction, primarily in individuals with obesity, of why they end up coming into a positive energy balance on a long-term basis. We're all in positive energy balance off and on in the course of our day or weeks, but we don't necessarily develop obesity. Individuals with chronic obesity have a dysregulation of what is it that causes them to be in positive energy balance for a long period of time. And that's complex, right? Social determinants of health, built environment, where you live, where you play, enticing foods, but it's this dysregulation of appetite that causes them to take in more than their body should be taking in. And these drugs directly impact that appetite dysregulation. So that's how they work. And you look at the very bottom here, I just put a red circle around it. GIP finally came back and now has a role in treating not only diabetes, but also obesity. After all this time, we're understanding how GIP can work when it's given along with GLP-1. So these are the medications I just talked to you about, all orlistat to the left, all the way to tirzepatide to the right. And what I'm showing here is the mean % weight loss, drug versus placebo. These are all non-diabetes studies, just pure obesity, no diabetes. And I'm showing you placebo versus drug, and for each of these drugs. And on the x-axis are the actual randomized placebo-controlled prospective phase 3 trial studies. That's what they are. And I put a dashed line at 10% weight loss. Why did I do that? Because we've talked for such a long time now, if we were able to develop drugs that routinely produce more than 10% weight loss in our patients, we would get interested in it and be activated probably to get involved and treat obesity. Patients would start noticing a difference that's worthwhile taking the drug, and the patient's health would improve with a 10% weight loss or more. And you see, we finally reached that with the release of semaglutide and tirzepatide towards the right. In all these trials, people lose more weight on drug versus placebo. So all these drugs can help people. But the point of this slide mostly is there's been an inflection point with the development of semaglutide and tirzepatide. And that, in large part, is what got the excitement of social influencers and patients and so forth, beginning in 2021 with the FDA approval of semaglutide under the trade name Wegovy. What I'm showing you here is not mean weight loss, but categorical weight loss. So this is the percent of individuals with each of these drugs that are losing either 5, 10, 15, 20, or 25% weight loss. And what you see, again, towards the right, is the number of the percentage of people that are losing each of these categorical weight loss is incredibly impressive. Let me just pick one for you as an example. If you go all the way to the right, which is tirzepatide, 15 milligrams, 36% of individuals in the trials, more than 1 out of 3, are losing 25% of their body weight at the end of a year. That is a profound amount of body weight. So if you come in weighing 200 pounds, right, that's 50 pounds you're losing. 25% of your body weight, that's just a tremendous amount. So again, that's where the excitement has come up. The other thing is the two companies that are primarily driving this, which is Novo Nordisk and Lilly. Those are manufacturers. To their credit, they have this large portfolio of phase 3 studies they're looking at. So the goal now is not just how much weight loss can we achieve in an individual. What they're looking at, to their credit, is obesity as a disease. And if you look across all these STEP trials, that's what they're called, they're looking at it in individuals with obesity, with type 2 diabetes, in adolescents, different racial and ethnic groups, in knee arthritis, cardiovascular disease, reversing pre-diabetes. So these are all the trials, and you could look all these up yourself. Heart failure, which with preserved ejection fraction. All of these are going. You can see a lot of them have been published already. Surmount is the phase 3 trial for tirzepatide, and they are doing a parallel amount. And I'm sure I did not capture all the studies they're doing. These are ones that I'm familiar with. Again, many of them already published, some of them not. They're also doing a cardiovascular outcome trial called Surmount MMO. They just published the Surmount OSA with a profound 20 event, the AHA, the apnea-hypopnea index reducing 20 per hour in those individuals on tirzepatide versus those on placebo. I mean, this is really significant stuff, also looking at heart failure. So what I wanted to do for the next few minutes is to just go through, I'm going to have to do it fairly quickly, some of the data so you can get a sense of where that excitement comes from and clinically get a handle on what these drugs actually produce. And I'm going to show you the parallel studies between semaglutide and tirzepatide, because they almost did the same studies, which is nice because it reinforces that it's not a one and done, one trick pony drug. Other drugs can reproduce it that are equally powerful. So these are the pivotal trials from semaglutide and tirzepatide, where you see on the top is the weight loss curve in those in a placebo versus on the drug. The STEP trials are 68 weeks. The tirzepatide trials are 72 weeks. But you see a commonality here. You see the rapid weight loss early on, all the way to a weight stabilization out to about a year, stabilized at 15% for semaglutide and about 20% for tirzepatide. And at the bottom, what you see are the categorical weight losses. Again, really profound. I want to add something, though. Not every person responds. If you look at these trials, at least in the STEP trial towards the left, 14% of individuals in that trial did not lose at least 5% of their body weight. And we call that kind of non-responsive if you don't lose at least 5%. With tirzepatide, 9% were unresponsive. So clinically, you have to look at your patients and make that determination. Not everybody responds. The STEP trial went out to 2 years, and what they showed is that individuals on these drugs lose weight over the first year, and you see that towards the left. And then as long as you stay on the drug, your weight stabilizes. So that's a nice take-home message when you're talking to patients. The way these drugs work is over the first year, stay on the drug. In general, your weight is going to remain stable. And you see towards the right the absolute weight losses. And in this 2-year trial, what you see is not just the weight loss, but you see the accompanying improvement as I go across these different parameters, an improvement in waist circumference, systolic blood pressure, diastolic pressure, and inflammation, C-reactive protein. And if you look across the baseline values, which is towards the top, these are people that are in pretty good control. So on top of good control, you're still seeing a reduction in these parameters. And here's some other parameters. These are individuals without diabetes, and yet hemoglobin A1C is reduced 0.4%. Blood sugar was also reduced 7 millimeters per deciliter. Insulin came down. Triglycerides came down profoundly. So individuals are losing weight and associated improvement in cardiovascular improvement. The other interesting thing is, although individuals in this STEP trial did not have diabetes, about half of them had pre-diabetes. So if you look at those with pre-diabetes, 50% of semaglutide arm and 42 placebo arm, and you look what happened to them, the vast majority of semaglutide arm reverted to normal glycemia, and in placebo, it actually increased. More became a pre-diabetic, had pre-diabetes. So also very interesting regarding treatment of pre-diabetes. Now, I showed you if you stay on the drug, the weight is maintained. But what happens if you suddenly stop the medication? Well, that was looked at in the STEP 4 trial and the SURMOUNT 4 trial. To walk you through this quickly, these trials, everyone got drug over the first 20 to 36 weeks. That's why you see one line. They lost about 10% of their body weight with semaglutide and about 20% of their body weight with tirzepatide. At that point, individuals were pre-randomized, or not pre-randomized, they were randomized to either stay on the drug or go off the drug. So these are people who stayed in the trial, seeing the interventionist, coming in for the clinical trial. The only thing is that they didn't know if they were randomized to placebo or staying on the drug. And this is what both of the studies showed. If you stay on the drug, you continue to lose weight, profound amount of body weight out to the end of the trial. If you were blindly randomized to placebo, you've regained about half of your weight back, showing, I think, highlighting the underlying biology of obesity, because they were doing everything right. They were in the trial, they were following the diet, they were physically active, and yet if you take the drug away, the disease came back. Really profound example of that. The other thing about the GLP1 receptor analogs is not only are they effective in appetite, which I think I showed that very nicely, but what's also exciting is the pleiotropic effects of GLP-1. So it's not just working in the brain, it has direct effects on liver, kidney, blood vessels, myocardium, and so forth. And that then launched, in large part, why the SELECT trial was done. Now, this just came out last November, so it's very exciting. I'm going to walk you through it quickly. The trial was done in individuals with obesity and pre-existing cardiovascular disease. That's called the secondary prevention trial. And we looked at the reduction in MACE, major adverse cardiac events, which was a combination of death from CV causes, non-fatal MI, and non-fatal stroke. That's the upper left. And individuals with obesity or overweight, no diabetes, were randomized to semaglutide or placebo, looking at what was the effect on MACE. And this is what we found. After about 3 to 4 years, what you see towards the left is a 20% reduction in MACE in individuals with overweight, obesity, pre-existing disease who took semaglutide. The raw numbers were 8% versus 6.5% in development of MACE, which is a 20% reduction. P-value highly significant, less than 0.001. First time that has ever been seen. And it is important also to note that every additional parameter that was looked at as secondary outcomes were in the favor of semaglutide. I would be worried if something went to the other side of the dotted line, like everything looked well except increased stroke. Okay, we didn't see that. Now, not all of them were, some of them crossed the 95% confidence interval, but everything was towards the left, towards semaglutide, and that should be reassuring that this drug indeed improves cardiovascular disease as we would expect. And part of that reduction in cardiovascular disease was the improvement in the cardiovascular risk factors like waist circumference, blood glucose, blood pressure, CRP, triglycerides, and the weight loss was on average less than 10%. Weight loss was not the same in the STEP trials because this was not a weight loss study. It was a secondary prevention study. And once again, we also saw an improvement in those with pre-diabetes, which I'm showing you here. So let me, in the last few minutes before we end it and go over a Q&A, I want to give you a peek into the future. And this is a table that looks at, and not all of them, by the way, I just picked out the most important ones. You see the category towards the left. The vast majority of medications under development right now are nutrient-stimulated hormone-based therapies. If you look at the mechanism, which is the second column, the ones in yellow are already approved by the FDA, but the ones under it are starting to combine different nutrient-stimulated hormone combinations like GLP-1 with amylin or GLP-1 with glucagon, GLP-1 with GIP and glucagon. You see the drugs on the next column, the name of the phase 3 program, route of administration, what phase they're in. And in the last two columns, I just want to point out how exciting this field is. The second to the right column is weight loss as a percentage, and the last column is how many weeks the trials went on. And what you see there is that these are phase 2 trials, which typically run about 46 to 48 weeks or even 36 weeks. And look at the percent weight loss achieved, and it's not even a year yet. So these are highly effective medications that are on the horizon. I first want to look at more detail the combination medications. I put a box around them. And what you see here is that it turns out that GLP-1 appears to be the anchor drug for all of these. So GLP-1, you kind of see the kind of the string below it where you're adding different gut hormones to develop either di or tri or different analogs. And the considerations as a pharmacologist or a biochemist is, do you do mono, dual, or triagonism or a combination? Are you trying to have complementary action or diversity of target? What's the predominant agonism? Is it GLP-1? Is it amylin? And lastly, biased agonism. And that is, are you trying to get a different mechanism of action by combining these two products? So the example here is GLP-1 and GIP. This is what tirzepatide is. And what GIP adds is it's enhanced caloric reduction. It has separate effects on fat tissue as well as on the bone. And interestingly, which you probably are unaware of, tirzepatide actually has compatible affinity for GIP-1, for GIP, but it's five times weaker for native GLP-1. So it's actually a predominant GIP molecule, not a GLP-1 molecule. So there's so much about the biology we really don't quite understand. And we also want to think about different combinations. So if you add glucagon, what do you add? Well, you have an effect on the liver, which increases glucose production, potentially increasing lipid oxidation, which may be helpful for MASH or fatty liver disease. There's also some data primarily from animal studies that increases energy expenditure. And if you add amylin, you have other qualities as well. So I'm putting this as one example. It was just presented earlier this week, actually, at the ADA. That's why I'm putting it on here. But it kind of shows you what a typical phase 2 trial looks like. This happens to be pemvidutide, which is a GLP-1 glucagon analog. And in phase 2, if you're not familiar, you're testing different doses, which then go into phase 3. And what you see is a really nice dose effect of increasing the dose of the molecule, and you have greater weight loss in 48 weeks. Individuals in this trial are losing 15% of their body weight, which is what they lost with semaglutide at the end of a year, and the curve is still going down. So that's kind of exciting thing. Here's a triagonist, retatrutide, again, phase 2 trial, only 48 weeks. And I just want to highlight one thing for you. It kind of blows my mind, is that if you look towards the bottom right here, over half the individuals are losing 25% of their body weight, and now they're even looking at 30% body weight. So this is just unbelievable amount of weight loss, and it's also being looked at for other reasons. And that has led now to multiple recent publications of using these medications, not just for weight loss, but for OSA, for MASH, for heart failure, preserved ejection fraction, and other things like that. And before I leave this, just to throw a monkey wrench into the whole thing, This came out this year, we're still struggling to understand it. This is from Amgen. They actually developed a GIP antagonist, not agonist, but antagonist, which is based off of a GIP backbone, and they added an anti-GIP antibody to it. That's what it shows on the left. And towards the right, there's a phase 1 study. Just 3 injections, you're losing 15% of your body weight. Unbelievable. And there's a lot of trying to understand how is it that GIP agonism and GIP antagonism both lead to weight loss. So stay tuned. One other comment here, GIP-1 small molecules are now being developed for oral intake, which gets away from this weekly peptide injection, which paves the way for a daily oral medication. And lastly, to end up, I just want to mention one slide or two on the whole new area regarding obesity care, and it's monoclonal antibodies. One thing that we are becoming very concerned about by using these highly effective medications is the effect on muscle mass, right? If you lose 25 to 30% of your body weight and you're not exercising and you're not taking in a healthy diet with high protein, you're likely or at risk of developing a lot of muscle mass loss, so-called sarcopenia. So there's a whole new area of pharmacotherapy now that is geared towards either myostatin, which is a potent inhibitor of musculoskeletal development, or the receptor called activin type 2 receptors. And bimagrumab is a monoclonal antibody that's geared towards the receptor of myostatin with the idea of reducing the proteolysis of muscle. And only one study has been published so far several years ago looking at the effect of bimagrumab versus placebo. If you look towards the right here, I'm going to end it up here quickly, total body weight loss was pretty modest, only 6.5% at the end of the trial. But what the graph looks at is not body weight loss, but total fat loss, which was 20%. And they didn't lose lean body mass, they gained lean body mass. So very exciting direction. And this is my last slide. These are my conclusions, which I won't read, so I want to make sure we have enough time for Q&A. But it really just summarizes what I just told you. So having said that, I am going to stop sharing my slides and get back to ability to look at each other. Thank you.
All right, Dr. Kushner, that was incredible. A lot of really interesting data there. And maybe one question from me before I pass it to Ani to get us off with the Q&A. The data that you showed on there's a slide where you highlighted results from a study where patients were given the drug for some time, I think it was semaglutide, and then they randomly were taken off, and you saw that sort of rebound in their weight loss. And it kind of speaks towards the effect of the drug itself and like how it is directly mediating the weight loss. But I'm curious, it also seems like there's some role for the lifestyle changes that the patients are engaging with, and that might, to some extent, dictate success or failure with these drugs. And I'm wondering if you could say a little bit more about that. Sure. And teasing apart what's the drug and what's the lifestyle.
Sure. It was actually 2 studies. It was STEP 4 and SURMOUNT 4. It was actually semaglutide and tirzepatide. They did the exact same trials. Yeah. After a period of time when people lost weight, they randomized them blindly to either go onto a placebo or on the drug. And what it showed is if you suddenly stop the medication without the patient knowing it, it's hard for them to maintain the weight loss. In fact, they gain weight. So shows, I think, definitively, in my mind, that obesity is a biologically driven disease. And if you take away the drug, no matter how much they want to lose weight, they start gaining weight. So what's the take-home message clinically? 1, do not stop the medication blindly and don't tell them about it. So, because that's the way it was done. But the other is what needs to be studied today. And that is, what do we do to help people maintain weight loss? And I didn't go into any of that data with you, but we have very good data from behavioral trials that go back decades that by using self-monitoring and tracking, by diet, behavioral counseling using cognitive behavioral therapy, high protein diet, robust physical activity, both resistance and aerobic activity, accountability, looking at their lifestyle helps, because we have behavioral studies that helps people. We now have to apply all that information to these medications so we could either maintain the weight loss if they go off it, Or also, what are we going to do? Can we taper the medication? Can we use intermittent therapy? Can we change them to a more cost-effective oral medication so that these medications were in short supply can be used for other individuals? So these are all the remaining clinical questions we have that we don't have a definitive answer yet.
Yeah, that makes sense. Yeah, still a lot answered. I'll pass it to Ani because we do have quite a few questions in the Q&A, so we could walk us through.
Sure, yeah. Well, first off, yeah, thank you so much, Dr. Kushner. That was really fascinating talk. So yeah, I have a couple questions here in the Q&A. So I guess first is someone's asking if they'll get access to the copy of this deck. I guess I can answer. This is being recorded, so we'll
Yeah.
send that out for sure. But Dr. Kushner, I don't know if you're able to share your slides or not.
Sure, I'd be happy to share PDF copies. I can send them to you guys.
Okay.
Great.
Yeah,
And then we'll disseminate that as well.
Yeah.
Awesome. Thank you so much. Okay, so next question. Could you elaborate on the possible molecular mechanisms of the effects observed once patients stop taking drugs like semaglutide? Like what ends up happening, I guess, with the weight changes?
Well, if you take it from well, let me start with a patient perspective. The medication's working. They're not thinking about food. They're full sooner. They're not snacking. They're empowered. Their executive function is working better. They can problem solve through the situation. I know what my goal is. I can stick to my goal. And it takes that pressure away of counting calories and watching what I eat and recounting calories. The medication takes care of all that. Okay. You stop the medication. What happens to the patient? They're hungrier. They're thinking about food more often. They're not as content. They're searching for food more. It's almost like telling someone, hold your breath as long as you can, kind of like, I can't, if I'm hungry, I really need to eat. So that's what's happening. What's happening on a molecular basis is that the way we think about it, the underlying pathology of the appetite dysregulation in the individual is coming back. So if you want to get down to the neurons, the PY, the neurons in the hypothalamus are starting to trigger, which trigger more hunger. The reward centers of the brain are starting to light up more when they see chocolate cake or they get a smell of food. So all of these, which still needs better defined, but that's kind of how we think about it. It's like any other disease, that dysfunction of the disease is starting to come back without treating it pharmacologically.
Interesting. Very cool. Okay. Nice. Okay, next question then. Could you please talk a little in regards to the drug-drug interaction studies, if available? In particular, since semaglutide and tirzepatide decrease the rate of gastric emptying, this has implications for all medications that are of oral intake.
Yeah, there hasn't been, it's a good question. There hasn't been studied well. Drugs that, and it does decrease, although it does decrease gastric emptying in the acute phase. Many studies now show there's a tachyphylaxis, so it is not a long-term problem regarding the same amount of gastric inhibition or gastric emptying reduction from an acute exposure. So a lot of the studies, when you do gastric emptying studies in someone on these medications long-term, you don't see the same amount. We think it's a tachyphylaxis kind of a receptor downregulation type of thing. However, the question is a good one. If you need a reliable delivery of other drugs from the stomach into the intestine, it could potentially cause problems. From my point of view, it has been a insufficiently researched area. But clinically, where we see patients every single day on multiple medications, we have not seen case reports or a worsening of other conditions that may cue us in that there's something going on with it, like thyroid medication or beta blocker or an ACE inhibitor or something like that. We really don't see a change in the other comorbidities from those medications. Sometimes we are concerned about mental health issues because you want to be concerned about psychotropics and antidepressants, but we really haven't seen that. If you're interested in research, I think it's a great area to go into and actually study the pharmacokinetics and so forth of these medications, but we really don't have enough information.
Okay, nice. Okay, so the next question is, could you elaborate more on GIP resistance in diabetes? Is the resistance also in obesity? Is there any information available on GIP resistance in type 1 diabetes?
Yeah, there's there appears to be GIP does not in a setting of hyperglycemia where you have diabetes, someone with diabetes not under control. GIP, either it's at the receptor level or the internalization level. I don't recall. GIP does not have that glucose-dependent insulin secretion ability, so it's downregulated in the setting of hyperglycemia. So it affects either the membrane, or receptor, or post-receptor pathways. We now know that once hyperglycemia is controlled, that dysregulation is removed and GIP is now effective in causing insulin-dependent glucose release. So it seems to be in a setting hyperglycemia. In individual obesity who do not have diabetes, it's not a problem. And that's probably why tirzepatide is highly effective in those individuals. In retrospect, though, and this is the current thinking, although I'm not an expert in this area, why would tirzepatide work in individuals with diabetes? The thought is that the GLP1 molecules bring the sugar down, which then allows GIP to activate better. That's the current thinking of why tirzepatide appears to have augmented effect in people with diabetes. People with type 1 diabetes, it should be the same thing. It has to do really with hyperglycemia. Now, in type 1 diabetes, you might not have enough beta cell mass to actually have glucose-dependent insulin secretion from the beta cells. So you have to be careful in type 1. They may not have enough beta cells for activity. And it's also not approved in type 1 diabetes. It's worth noting. It's only approved in type 2 diabetes.
Interesting. Okay. Do you know if there's any studies happening that are exploring that more?
For type 1?
Type 1, yeah.
Oh, yeah. Well, having said that, off-label, we use it in patients with type 1 diabetes because we know that we can effectively reduce body fat. And by doing that, we could reduce insulin resistance. So we may not be able to improve the actual beta cell and pancreatic mass, but if we could reduce insulin resistance, we can at least improve the insulin that is there and potentially bring down their insulin they're taking, either short-acting or long-acting insulin for type 1 diabetes. So people benefit from it for that reason. But again, it's not approved, and I'm sure they're studying it.
Sure. Awesome. Thank you so much. So there's just one more question real quick. So someone in the comments says they're currently taking semaglutide for a month now. Now that you mentioned that there may be a bounce back, is there an optimal treatment period endpoint?
The drugs are approved for weight loss and maintenance of weight loss with no stop signal. That's number one. Number two, from a safety point of view, there are no safety signals that have arisen from the long-term use of these drugs worldwide. Ozempic was approved in 2017. So we have, 7 years of exposure of that drug worldwide, and no safety signals have arisen. So just to make sure, to let you know that we're not seeing safety signals and there's no stopping signal. But that still leaves the question, what do we do with all the people on the drug now if you can't make enough? And that's where the research is going into to identify minimally effective dose, so you're getting the whole dosage down, or potentially going to another lower cost drug, which I mentioned, which may be oral. Some of these older, earlier drugs may be more effective in someone that's already lost their weight. So they may be more effective in weight maintenance where they weren't effective in weight loss. Or, of course, how do we get people off the drug possibly? I want to reinforce the study I showed you was a sudden discontinuation of the drug. We don't practice clinically. If you have someone with depression who wants to get off medication, rarely would you stop the medication, or blood pressure, right? Hypertension. We typically taper the medication. We see them back. We make sure they're in good control. We almost rarely stop a medication right away and don't tell them, which is what the study was. So you have to be careful extrapolating that data to real life.
Very interesting. Okay.
Good.
I think that's the last
All right.
one.
Oh, go ahead. Oh, sorry. I thought you had. Is there another question in the chat?
No,
I think
that's it.
I think we wrapped up. Yeah.
I think that's everything.
So yeah, thank you, Dr. Kushner, again. Very
Welcome.
fascinating talk, and thank you for offering your perspective on sort of best use cases and sort of the experience, or talking a little bit about the experience of patients on these drugs as well. And thank you all to our audience for joining. And with that, I think we'll wrap up. So thank you again to Dr. Kushner.
Thank you all for attending. Appreciate it.
Yeah. All right. Bye, everyone.
Bye.
Okay.